gets better, all of us can get better.
Good afternoon and welcome to this forum. First of all, my name's Dr. Chris Pillay. I'm a geriatrician and chair of Dementia Trials Australia, clinical trials network of centres conducting research in Alzheimer's dementia and other dementias across Australia and New Zealand. I'm also a geriatrician working at the Prince Charles Hospital in Brisbane. First of all, I'd like to acknowledge the traditional owners of the land at which we are here, the Gadigal people, and acknowledge their past, present and emerging elders. We're entering a new era in Alzheimer's disease. Advances in biomarkers, earlier detection, clinical trials and disease-modifying therapies are changing what is possible for patients, families and healthcare systems. It's now almost a year since the first disease-modifying therapy in Australia was approved by the TGA, namely Donanemab, and now there is another, lecanemab also has been approved. Today's session brings together leaders in Alzheimer's disease research, clinical trials and therapeutic developments who are helping shape this rapidly evolving landscape. We will hear about advances in risk prediction, screening and trial readiness, long-term outcomes from anti-amyloid therapies, and emerging insights from global real-world studies. Our four speakers today are Associate Professor Emma Devenney, Associate Professor Steve Macfarlane, Associate Professor Paul Yates, and Dr. Vinay Prusty. Each presentation will be around 10 minutes. There will be time for question and answer after each presentation. If you would like to come to the microphones at the end of the presentation, that'd be most appreciative. Our first presenter is Associate Professor Emma Devenney. Emma is a cognitive neurologist and clinical scientist at Neuroscience Research Australia and at the University of New South Wales. Her research focuses on biomarker-driven diagnosis, early detection, disease stratification and trial readiness in neurodegenerative diseases. Please welcome Associate Professor Emma Devenney.
Thank you, Chris. It's my pleasure to be here today to talk to you about this really exciting study, Prognostic Models for the Development of Elevated Plasma p-tau217 in Cognitively Unimpaired Individuals. And this data is drawn from the A4 and the LEARN studies. These are the authors' disclosures, and the authors acknowledge the study participants and their study partners. So by way of background, I don't think I'll have to convince anyone here today that plasma p-tau217 is a highly sensitive and specific biomarker of AD pathology, identifying individuals at high risk of developing elevated p-tau217. This p-tau217 is accessible and scalable when we compare it to amyloid PET or CSF testing. So the question in this study was, can we look at cognitively unimpaired people today? So today they're cognitively unimpaired. Is there a way that we can predict who of these people will eventually have elevated p-tau217? If we can answer that question, then we've unlocked two major opportunities. One in terms of early targeting on a community basis and screening, and then secondly in terms of enrichment for clinical trial participants for prevention-focused trials. So with all of that in mind, this study set out to identify baseline demographic, genetic and clinical factors that are most strongly associated with the development of elevated plasma p-tau217, then to develop sort of robust prognostic models for plasma p-tau217 in these cognitively unimpaired individuals, and then to rigorously evaluate these models for internal validation, looking at discrimination factors and calibration to see if people can be truly stratified into risk profiles. So there's a lot of words on this slide. I'm just going to try and condense it down. Essentially, as I said, this was retrospective, looking at the A4 and the LEARN studies. The A4 study was anti-amyloid treatment for asymptomatic Alzheimer's disease. So these people all had abnormal amyloid PETs, but they were cognitively unimpaired. And then LEARN was the companion study. Again, these individuals were all cognitively unimpaired, but they had normal amyloid PET scans. So people were included in the study if they had normal p-tau217 or not elevated p-tau217 at baseline, if they had at least one study visit, and they were cognitively unimpaired. Struggling to read that. Okay, so the outcome, that's hard to see. The outcome was determined by the time to elevation of p-tau217, and that was set at a limit of 0.28 units per mil. And then the predictors were determined based on a number of variables, and when this was put into, so the statistical analysis had two steps. The first was what's called random survival forests. What that does is it puts all the predictors into the model in a machine learning model, and it determines which are the biggest predictors or the best predictors of elevated p-tau217. What that showed was the baseline p-tau217 levels, along with the delayed logical memory score, along with the functional cognitive index, and along with the PAC score, which is the preclinical Alzheimer's composite clinical score, along with age. Those were the best predictors. So using those predictors, then the next stage was a Cox regression analysis. What that did was determine the risk of time to onset of elevated plasma p-tau217. The predictors that were put into the model were determined based on statistical significance, of course, but not just that, also on clinical relevance and feasibility. So for that reason, the models, there were three models. Model A included plasma p-tau217, age, and education. Model B substituted plasma p-tau217 for ApoE4 status and also included age. And then Model 3 was the most parsimonious, and that included age and education. Within those models, participants were then classified into low, medium, and high-risk groups using empirical cutoffs, and Kaplan-Meier curves were then used to visualize that 5-year cumulative probability. Okay, so the headline results first. Essentially, 22% of the entire group progressed to have elevated p-tau217. That was about 194 from 881 participants. Model A was clearly the best performing model. If you can see there, the C value was around 0.8 compared to Model B and C, which sat around 0.5 and 0.55. And then figure 1, you can see here is the Kaplan-Meier risk stratification. That really brings the clinical relevance to life. Using Model A, we stratified participants into low, medium, and high-risk groups, and the Kaplan-Meier curves show this clear, sustained separation over the 5-year follow-up program or window. So as you can see, by year 5, that high-risk group, which is in the red, showed substantially higher cumulative probability of p-tau217 elevation compared to the low-risk group. And that's exactly the kind of prognostic separation we want to see when we're thinking about screening people in a community setting, and also in terms of enrichment strategies. So going back a little step, now we've seen the headlines. How were the patients selected? Well, starting from the A4 and the LEARN study populations and applying these eligibility criteria, cognitively unimpaired, a non-elevated baseline, p-tau217, and at least one follow-up, yielded the final cohort of 881. You can see on the flowchart there how that was worked through. In terms of the predictors, so to briefly summarize, the predictor findings alongside the table, baseline p-tau217 was the predominant predictor in Model A. In fact, its effects dwarfed the others on a per unit basis, reinforcing why plasma biomarker data, where available, is so valuable for this individual risk stratification. The age effect was consistent across all three models. Participants aged 70 to 74 had roughly 1.4 to 1.7-fold higher risk than those under 70, with a similar pattern for the 75-plus group. And then lower education, representing cognitive reserve probably, was also consistently associated with elevated risks. So the baseline characteristics, and I guess this points to some of the limitations of this study, as we know is common in many trials. The mean age was 70.6, about 38% were male. The cohort were predominantly white and highly educated, with a mean education of around 17 years. And these demographics reflect the sort of trial populations from which they were drawn. From a genetics perspective, 47% of the cohort carried at least one ApoE4 allele, with the A4 subsample having a higher carrier rate at 57%. That's reflecting that elevated amyloid selection criteria for that trial. Similarly, baseline p-tau217 was also notably higher in the A4 group, again consistent with the amyloid PET stratification. So in conclusion, and I cannot read what the conclusion says down there, but in conclusion, p-tau217 has emerged as a robust predictor of subsequent elevations in p-tau217. The best performing model, which included the baseline p-tau217 age and education, demonstrated the highest discrimination and clear separation of 5-year risk groups. So that C value and the 5-year area under the curve of around 0.75 to 0.88 is really quite high and considered to be good, much and outperformed those models B and C. However, those simpler models, based on demographics or genetics alone, still provide some feasibility when you don't have plasma data biomarker data available. Prognostic models incorporating demographics, genetics, and plasma biomarker data can identify individuals likely to develop plasma p-tau217 elevation, thus supporting early screening and enhancing clinical trial enrichment in populations who are cognitively unimpaired.
Are there any questions for Emma? Emma, if there are no questions, can I just take you back to that value of 0.28, I think is the cutoff? Mm-hmm. Would you like to comment on that?
So the 0.28 was empiric cutoff determined by the A4 and the LEARN trials, and that's been consistent with what has been reported in previous studies. But I think it is important to note that that is a study-specific cutoff. I guess essentially what the study really shows us is that it's the progression or the change in p-tau217. So perhaps regardless of what you choose the cutoff to be, certainly what it's showing us is that there is a trajectory of p-tau217, and perhaps we can harness that to help us prognosticate a bit better.
Thanks so much. Henry.
Henry Bradati, Sydney. Emma, in the graph where you showed the survival curves, maybe you could bring it back up if that's...
Yeah, sure.
That one, yes.
Yep.
How come it goes down? It must be an artifact of follow-ups, but you've got a straight line almost from year 1 to year 4, and then another drop. Is that just because of the assessments? And
well, I
think you just see a straight line going down. Yeah.
Yeah, and I think that sort of speaks to some of the potential limitations of the study, in that people were included if they were they only had to have one follow-up p-tau217, and there were 3 time points in the trial. So, I mean, certainly there may well be a lot of nuance missed in that sort of, in that in-between time points, I expect. And also, we don't know, because of the statistical analysis, we don't necessarily know, is there a threshold, at which your p-tau217 starts to suddenly rise.
Drop off a cliff or whatever.
So it's not necessarily linear, I guess. Yeah. So I think, that does speak to some of the limitations within the study.
Thank you.
Thank you. Very nice talk. You combine your cohort A4 versus LEARN, right? Your A4 is unimpaired but have amyloid. Your LEARN has unimpaired, low amyloid. Do you see the p-tau prediction different in these 2 cohorts? Because one started with amyloid, one have no amyloid. They both are unimpaired. Do you see the p-tau develop differently? Do you look at the muscle separate the p-tau changing in 5 years, not together, but in 2 separate cohorts? Do you see any difference?
I don't have the answer to that, what they look like in the different trials, but I do know that at baseline, the p-tau217 was higher in the A4 study. Whether we can, we don't. I think we don't know the answer, and perhaps looking at this data in a slightly different way may well tell us that. Looking at threshold-based and a variety of different statistical methods might help answer it.
Thank you.
But that's a good question.
Just my quick question.
I'll be quick, I promise. G'day, Brendan Boots, neurologist. I actually worked on this study back in the day. Now I have a cell therapy company, work with Southern Star. My question is about the same thing Henry had. There's a dip at that right curve that's more or less immediate. Is this saying that somebody then saw the p-tau and then was able to diagnose straight afterwards? Why is there an immediate dip? The red curve goes down immediately.
Yeah. Why is there?
And if this was a clinical endpoint, that's progression here, is that why? Did those people get evidence of that p-tau and then were able to, was that how they were affected to make a positivity more or less immediately?
Yeah, that's a good question. I don't have the answer to that. We don't have any of the clinical data from that. It's a good inference, I guess, but I don't have the answer. I haven't seen the raw data.
Thank you.
Thank you. I think that's time. Would you like to thank Emma for the presentation? I'd just like to introduce our next speaker, is Associate Professor Stephen Macfarlane. Stephen is the Head of Clinical Sciences, Dementia Support Australia, Associate Professor of Psychiatry at Monash University, and he's one of Australia's most experienced Alzheimer's disease clinical trial investigators with more than 25 years of involvement in dementia trials. Please welcome Associate Professor Steve Macfarlane.
Thanks, Chris, and thanks to Lily for the opportunity to present. I'm presenting on behalf of the Trailrunner-3 study team, and it's a pleasure to share these data here today at the ADRF, particularly given Australia's involvement in this global trial. Today I'll be walking you through the screening outcomes and baseline characteristics of this phase 3 trial investigating subcutaneous Remternetug in early stage Alzheimer's disease, stages 1 through 3, prior to dementia onset. The disclosures are available on screen, and you'll note that the authors are all full-time Eli Lilly employees and company shareholders. An overview of the molecule itself. Remternetug is an IgG1 monoclonal antibody targeting an N-terminal pyroglutamate amyloid epitope. Critically, this epitope is present only in the deposited brain amyloid plaques, not in soluble forms. The mechanism involves subsequent microglial clearance of these plaques. 3 particular properties make Remternetug compelling. The first is that it's got a very low rate of anti-drug antibody development. Secondly, it seems quite potent in terms of being able to rapidly remove amyloid load. The phase 1b data showed that clearance can be achieved in as few as 3 months. Finally, the molecule has properties that make it suitable for subcutaneous administration, which is important in chronic disease management and will be a cost saver in terms of reducing the need for costly infrastructure like infusion centres to facilitate administration. The rationale for the drug is quite straightforward. We know from emerging evidence across previous trials of drugs in this therapeutic class that earlier intervention receives greater clinical benefit. Trailrunner-3 was specifically designed to test subcutaneous Remternetug in AD stages 1 through 3, that is cognitively unimpaired individuals with AD pathology and those with mild cognitive impairment due to AD, but crucially prior to the onset of dementia in those individuals. And today's focus is on characterising the enrolled population for the study. So key inclusion criteria: targeted participants aged 55 to 80 with plasma p-tau scores consistent with abnormal brain amyloid, an MMSE of 27 or above, and an FAQ score below 6. The inclusion criteria, you'll see, are fairly standard for most dementia trials nowadays. The graphs on the right illustrate what these clinical criteria were anticipated to select for. Applying the MMSE and FAQ criteria to the ADNI dataset shows a population predominantly at CDR global score of 0 or 0.5, with very limited representation of individuals above 1, essentially excluding dementia in this group. Similarly, applying comparable criteria to the A4 trial data shows roughly 80% of participants without an elevated global p-tau signal, confirming an early pathological population in the study. The study design was designed as a multi-centre, randomised, double-blind, placebo-controlled, parallel group, event-driven phase 3 study, the primary endpoint being a time to clinically meaningful progression, defined as an increase from baseline CDR score. Participants are randomised to subcutaneous Remternetug or placebo during a 78-week double-blind treatment period, followed by an observation period with dosage interrupted, with visits for evaluation every 26 weeks. And this observation period continues until the target event count is achieved, up to approximately 234 weeks. There's an open label extension available to eligible placebo participants if Remternetug met defined success criteria, and a subset of participants in the study underwent amyloid and tau PET imaging as well. The study has a broad demographic footprint, or geographic footprint. Over 39,000 individuals were screened globally, with 1,353 being randomised across 9 countries and territories. 2/3 of participants had a CDR global score of 0, and 1/3 having a CDR above 0. Of particular relevance to this audience, Australia contributed 43 randomised participants across 10 active sites, so a meaningful contribution from the Australian dementia research community, and many of you in this room will have contributed to that effort. The broader Asia-Pacific representation is also notable, with Japan, South Korea, Taiwan and China together contributing nearly 19% of the randomised population alongside Australia's 3.2%. The cohort had a mean age of 72 years with a slight female predominance at 59%. A 20% Asian representation reflects this strong Asia-Pacific enrolment I just mentioned. ApoE carrier status was approximately 52%, with a roughly 10-to-1 representation of heterozygotes to homozygotes. Cholinesterase inhibitor and memantine use was low overall at 6.5%, though notably higher in the CDR greater than 0 group at 14%, which is perhaps as expected. It was a reasonably diverse cohort overall, with the exception of the relatively low percentage of African American participants. Baseline clinical characteristics. Baseline clinical scores really confirmed the early stage profile of the population in the study. The mean MMSE was 28.7, consistent with intact global cognition. The CDR sum of boxes was 0.5 overall, 0.1 in the CDR 0 group, and 1.4 in the CDR above 0 group. FAQ scores were low, and MOCA scores averaged 23.4, with the expected separation between the CDR subgroups. The Cognitive Function Index showed a consistent pattern where study partner ratings diverged from participant self-report, more markedly in the CDR above 0 group, which is clinically expected. In other words, caregivers tend to rate patients at that point better than the patients rate, or worse than the patients rate themselves. And mild behavioural impairment scores across both groups were also low. We have some PET imaging data from a subset of participants in the study. So in the PET addendum group, the amyloid and tau profiles were consistent with early stage Alzheimer's disease. If you look at the amyloid burden by centiloid range, both CDR subgroups show a distribution that's centred in the moderate range. For tau, the key finding is that across both subgroups, the majority of participants had low Alzheimer's disease signature neocortical tau SUVR. The mean was 1.02 in the CDR 0 group and 1.05 in the CDR above 0 group. And this profile confirms that we really have enrolled a population that's early in the pathological cascade of Alzheimer's disease. Let me close with our conclusions. So in summary, the Trailrunner-3 trial successfully enrolled people in AD stages 1 through 3, those with cognitively unimpaired AD pathology and MCI due to AD pathology as intended. The baseline demographics of the group, their clinical characteristics and the PET imaging data all really confirm that this is an early stage population with established amyloid pathology, but limited tau burden and largely preserved cognition as a result. This global study will test whether Remternetug can delay clinically meaningful progression in these earlier disease stages. And with 43 Australian participants across 10 sites, our local research community is directly contributing to answering that question. As results emerge, they'll be directly applicable to Australian clinical practice and will inform how we think about early intervention in Alzheimer's disease in this country. I'm happy to take any questions.
Any questions for Steve?
I have a question. Thanks for your talk. My question is in relation to the exclusion criteria. Why was the cutoff of greater than 1 microhemorrhage applied when the current therapies, Donanemab and Lecanemab, have it in the label that it's greater than 2 microhemorrhages that the therapy would be contraindicated? Is it because you're really testing the safety profile in a preclinical?
I suspect it's because that this study was being planned before we had the outcomes of the earlier studies that might have informed otherwise, but it's a cautious limit.
Yeah.
I agree, yeah.
Thank you.
I suppose I could ask you a question, Stephen. Given if the efficacy is similar or similar, I suppose we don't know, obviously these are the baseline characteristics, but just in terms of your thoughts on subcutaneous versus intravenous administration? How could that be a game changer, do you think?
Well, I guess currently with only intravenous disease-modifying therapies available, we need a lot of infrastructure to support that, particularly around infusion suites, most of which are in public hospitals and are populated by cancer patients. There's not much room in existing capacity infusion centres for Alzheimer's disease patients. So if the market for these drugs is very large, the infrastructure capacity of the Australian environment to deliver them currently is very low. In this study, we're giving people their first subcutaneous injections in the clinic, and we're then teaching them how to self-inject at home or with the aid of a community nurse if desired. So it'll decrease infrastructure and therefore overall administration costs. The duration of treatment also potentially being much less as well. I mean, I know we're treating people actively in this trial for much longer than the 1B data suggests that we might have to, with, you know, basically amyloid clearance being achieved in as few as 3 months. But it could be a game changer in terms of convenience and therefore cost and access to drugs.
Amy.
Thanks, Chris. Amy Brotman, Melbourne. Thank you, Steve. Great presentation. Disclosure, I'm a PI and a trial runner. How are we defining clinically meaningful progression? Because it's a topic that's coming up again and again. What are the outcomes that we're looking at and what's the change?
Thank you. I guess this study defines clinically meaningful depression as a change in their CDR score. So a change from zero status to 0.5 or 0.5 to 1.
Okay, so 1 point change.
Yep.
Well, if there's no more questions, there's one last question.
As the antibody is going to bind with the amyloids, means there are other correlative markers we should take care during the exclusion and inclusion. For example, a person having diabetes or insulin resistance, that can affect the antibody effects also?
I'm not sure I understood the question, but the exclusion criteria in this study were fairly standard for AD trials. You know, if there's another significant neurodegenerative condition present, if there's stroke, if there's significant vascular disease, if there's a major psychiatric condition that might affect the results of the cognitive outcomes, for example. But I don't think we're doing any peripheral biomarker exclusion measures, if that was the thrust of your question. Yeah.
Yes, that we can analyze in a correlation manner similar to this, that whether the markers would be affected the antibody reaction or it can able to affect or not, that we can analyze afterwards.
Okay, I'll take that as a comment. Thank you.
Thank you.
Just like you to thank Steve for his presentation. Thanks, Steve. Our next speaker is Associate Professor Paul Yates. Paul is the Director of Research and Cognitive Dementia Memory Service at Austin Health and Chair of ADNET Novel Dementia Therapies Community of Practice, which I'm sure he'll explain further. He has extensive experience leading Alzheimer's disease clinical trials and implementing disease-modifying therapies in Australia. Paul's presentation today is Donanemab in early symptomatic Alzheimer's disease, additional insights from the Trailblazer-ALZ to long-term extension. Thanks, Paul.
Thank you. I'm going to try and read notes from my computer because I don't trust that I can read this slide either, having seen everyone else's struggles. So thank you for having me. Here are the disclosures. Thank you. All authors, apart from myself, are employees and minor shareholders of Eli Lilly. My disclosures are also here. I received honorary from Eli Lilly, Roche, Biogen, and Novo Nordisk. And we acknowledge the contributions of the participants and caregivers as well. So this presentation will show us specific aspects of the Trailblazer-ALZ 2 long-term extension study. In particular, we'll present long-term safety and efficacy data for a specific subgroup of patients that met treatment completion by 52 weeks. An additional objective of this presentation will be to compare efficacy of this subgroup to all participants taking Donanemab at the start of the Trailblazer 2 study. First, a reminder about the study design. So Trailblazer-2 started with a double-blind placebo-controlled period, which randomised participants 1-to-1 to donanemab or placebo. A key aspect of the study was the potential for participants to complete treatment with donanemab if they successfully cleared amyloid at 24, 52 or 76 weeks, determined by PET scans. The double-blinded long-term extension was an opportunity to study the long-term efficacy and safety of donanemab. This was an additional 78 weeks, and participants and investigators were not aware of who was receiving study drug. So all participants initially randomised to donanemab, as I'm going forward, will be referred to as the early start group. And amongst participants randomised to donanemab in the placebo-controlled period, most who continued into long-term extension were on placebo after having already met treatment completion criteria. Whilst not a focus of this presentation, all participants initially randomised to placebo who entered into the long-term extension began receiving donanemab infusions in a design that mirrored the placebo control period. Oh, sorry. First, let's have a bit of a look at the baseline characteristics of the participants at the start of the Trailblazer-ALZ 2 study. Apologies, I hope that project's okay for you. On the middle row, we show demographics of all of the early start participants randomised to donanemab, and on the right column are the demographics of the smaller subgroup of patients meeting that treatment completion criteria by 52 weeks. Many of the baseline characteristics are comparable. However, there are some notable differences, and you can see that ApoE4 carrier status was different. Participants meeting treatment completion by 52 weeks had a higher percentage of non-carriers. In addition, participants meeting treatment completion criteria by 52 weeks also had higher mini mental state examination scores and lower baseline mean amyloid levels. To determine the effect of treatment on clinical efficacy, the team analysed CDR sum of boxes scores. Now, since there's not a matching control cohort receiving placebo treatments throughout the duration of the study, obviously in the open label extension, there's not a placebo group, so the team have used participants of the Alzheimer's Disease Neuroimaging Initiative, or ADNI, for comparisons. ADNI participants were selected based on presence of cognitive impairment and CSF tau to amyloid ratios, and this figure here shows the CDR sum of boxes scores for the initial placebo group compared to the group that's used as a control in the open label component. So this is the ADNI external weighted control cohort. And you can see that the CDR sum of boxes scores for both groups worsened similarly over the 18-month period, shown by that lowering line towards higher CDR sum of boxes scores. And so this ADNI group of controls was used for comparisons in the donanemab to the donanemab treated group in the open label study. So using the ADNI control cohort, the team aimed to understand the long-term benefit of taking donanemab, meeting treatment completion criteria and stopping treatment. For this graph and some subsequent graphs, we'll show the time in which participants were on donanemab, indicated by the arrow near the top of the graph. And looking at the clinical efficacy by CDR sum of boxes, we can see that at 12 months or 52 weeks, the participants meeting treatment completion had less decline on their CDR sum of boxes score, with an adjusted mean change of minus 0.6, indicating less clinical decline at 12 months compared to the ADNI control cohort. If we graph the ADNI weighted control cohort data extended through the long-term extension period, we can see that they continue to have worsening CDR sum of boxes scores. The ADNI weighted control reflects the natural progression of the disease. And when we look at the participants meeting treatment completion criteria by 52 weeks, we see that the difference between those participants and the ADNI control cohort continue to grow, which should be consistent with these evidence of a disease-modifying effect with donanemab treatment. The differences in CDR sum of boxes at 1.1 at 24 months and 1.3 at 36 months compared to 0.6 seen at 12 months. And this indicated that they'd continue to have less clinical decline at 1 and 2 years after they were no longer taking treatment. So, how does stopping treatment by 52 weeks based on treatment completion criteria compare to the full early start Donanemab group? So here we show side by side the clinical changes observed by the participants meeting treatment completion criteria by 52 weeks, that's the left graph, compared to the changes of all participants randomised to Donanemab during the placebo-controlled period. So that's the right graph, which was presented earlier this year. Early start participants that met treatment course completion criteria by, it's like a Dr. Seuss, isn't it? Treatment course completion criteria by 52 weeks showed similar clinical efficacy to the early start participants overall. And to investigate amyloid plaque reaccumulation, this graph shows amyloid levels for the participants who met treatment completion criteria by 52 weeks. And you can see that the mean level remained below 24 centiloids throughout the 3 years of follow-up. And these data, along with other Donanemab studies, gave an estimate of a reaccumulation of about 2.4 centiloids per year, a rate similar to the natural history of amyloid deposition. Here we look at the frequencies of ARIA events between the different groups. So the middle two columns, it's a bit of a busy slide, the middle two columns represent the early start participants who met treatment completion criteria by 52 weeks. The first of those columns are ARIA events from initiation of Donanemab until switching to placebo. The second of those columns are the frequencies from the time of switching to placebo until the end of the long-term extension. The last column provides ARIA frequencies for the participants who were randomised to placebo at the beginning of the Trailblazer-ALZ 2 study. And you can see that ARIA frequencies of the early start participants once switched to placebo are similar to those who were randomised to placebo during the placebo control period. In particular, when we look at the OAIR, or the adjusted incidence rates adjusted for the time period, we can see that the rates of ARIA-E and ARIA-H for participants meeting treatment completion criteria by 52 weeks after switching to placebo are similar to the rates of participants who were randomised to placebo at the beginning of the Trailblazer-ALZ 2 study. So, to conclude, participants with early symptomatic Alzheimer's disease that met Donanemab treatment completion criteria by 52 weeks sustained clinical benefits. Clinical efficacy continued to grow using CDR sum of boxes after completing treatment by 52 weeks. Mean amyloid levels remained lower than 24 centiloids at 3 years, and ARIA frequency from time of Donanemab treatment completion through to the end of the long-term extension was comparable to that observed in the placebo group during the placebo-controlled period of Trailblazer-ALZ 2. That's the end. Thank you.
Any questions for Paul?
Drawing the line back on the treated trajectory to where it hits the ADNI control group, looks like the benefit from treatment's extended to about a year, as opposed to 6 months at the end of 18 months. Do you agree with that?
This is what the data show.
Yeah, good, thanks.
Colin?
I just noted, I'll get Chris's opinion on it in a minute, but the rate of reaccumulation, can you just go forward a couple of slides? Next one, yeah, this one. The rate of accumulation of 2.4 a year, that is slower than what we normally expect. It's we normally expect 3 to 5 per year. Correct, Chris? Thank you. So it may be that with more studies, the rate of reaccumulation is less.
It's sort of knocked back. Thanks, Colin. And just to Chris's point, I guess, we have to take those comparisons always with a little bit of a grain of salt, because it's a control group that's not, it's not the original placebo control group, it's a matched control group from an observational study as well. So I think there's probably going to be some variation in interpretation of the difference between the open label and the selected control group as well, that you have to sort of take into account.
Paul, can I ask you a question? With amyloid therapies, always comes back to clinical meaningful benefit. From your perspectives, what would you say is a clinical meaningful benefit of these therapies?
I guess I'm an individual thinking, so there's a person answer, there's a clinician answer. There are lots of different ways to answer it, which is part of I guess the conundrum we have with how to best define clinically meaningful benefit. Because for some people, a change in sort of a delay in change in function of 6 to 12 months is very meaningful, and for others it may not feel as meaningful, and it's all in context of the costs and the burden of a treatment. So I think it's a really difficult one to answer. I think when you're looking at the CDR sum of boxes, we know what those steps mean in terms of they're indicative of drop down in function in at least one domain of cognitive and functional performance. And so that might mean from being independent with a task to needing assistance with that domain of tasks, I should say. So I guess it's a little bit difficult to unpack in a very quick answer, but certainly change at a group level in CDR sum of boxes may be meaningful. But what I find, not represented in this talk, what I find most meaningful are the changes in individual change, where you see a likelihood of change of a person's global score in CDR. I think that's a nice metric, because it really it resonates with our clinical evaluations, and we've seen from this and other studies that these therapies do impact on the risk of progressing to a more severe clinical disease stage. So I think that's a metric that people understand, and certainly seems to resonate with many.
One final question.
Thanks, Paul. What is your recommendation then in terms of clinical practice? So you have a patient, you're given Donanemab for say 52 weeks or whatever, amyloid is down. What do you do after that?
So I guess so this is showing us that if you treat to clear, and it's clear by 52 weeks, then you can come off Donanemab and have an equivalent outcome to someone who was treated for longer, from my interpretation of this. So my practice would be a little bit of a shared decision-making process, where I'd look at the baseline characteristics of that person and take into account their attitudes to treatment, their means as well, and what they would want to do. If someone had a very high baseline Centiloid, then we might not opt for re-evaluating their PET for a little bit. But if someone had a medium or lower level high baseline amyloid, and they had the means and the will, then perhaps people like that might choose to recheck at 6 months. So I think it's got to be a judgment call, taking into account the biological characteristics, the personal motivation, and I guess the ecosystem and assets around them at this point in time, as we sort of find our way with these decisions.
Okay, can I ask you a follow-up question? Is that, have you had any patients who do reaccumulate amyloid and that you go back again for another course of Donanemab?
I have not, and I don't know if that data is being collected in real world. And I think that in terms of the implementation in Australia, the time frames for that to have occurred is probably too short.
Thanks, Paul. I think that's time. Thank you very much. Our final presenter is Dr. Vinay Prusty. Vinay is the Executive Director of Medical Neuroscience at Eli Lilly. Vinay brings extensive international experience in clinical development, medical affairs, regulatory strategy and neuroscience innovation, with a focus on advancing treatments for Alzheimer's disease and other neurological disorders. Vinay's presentation today is Cognitive Trajectories in Alzheimer's Disease, Findings from the Multinational CICERO-AS Chart Review Study. Thanks, Vinay.
Thank you, Chris. I'll take a cue from Paul, and I bring my laptop as well. Well, first of all, thanks for the opportunity to speak. And thank you to the chair, Dr. Stephanie Ward, and the team behind for a wonderful ADRF Congress. This is my third ADRF Congress on a trot, and every year I say that maybe one is better than the other. So probably Ralph has a better job to do next. But thank you so much for a wonderful ADRF Congress. I'm a shareholder as an employee of Eli Lilly, and this paper was presented on behalf of the authors at the CTAD Congress last year in 2025. And I thought maybe this is to bring in terms of as there has been an evolution in the disease, evolution in the diagnosis and the treatment, we thought that there might be something where we can look at some chart reviews on a real-world evidence to see how this fares in terms of from a diagnosis or in terms of from a prognosis or thereafter. So I'm an employee. And just to kind of like begin on in terms of the background and the narrative, so we know that Alzheimer's disease is a progressive neurodegenerative disorder, and it's marked by one, cognition, second, functional, and third, obviously, the behavioral decline. While the overall trajectory is one of in terms of from a gradual deterioration, we see that there is substantial heterogeneity. And this could be in terms of some might be a fast progressor, some might be a slow progressor into the disease. So we don't know in terms of what's the reason behind, and we looked at this chart review in order to see if there is any possibility, because thinking about in terms of designing new clinical trials, as well as in terms of ensuring that an early diagnosis and accurate diagnosis is important, how personalized care comes in terms of both from the caregivers as well as the support work, and how this corroborates the real-world longitudinal data on the disease progression, where we have seen as evidence shown by Dr. Steve Macfarlane, also by Dr. Paul Yates with regarding the evidences in the phase 3 trial program. So this study was primarily to characterize these cognitive trajectories in AD and explore in terms of kind of like the differences between the countries. This was primarily done in 5 European nations or cities, including UK. And we thought of in terms of seeing the differences between these healthcare resources utilizations. When you look at in terms of the study design, it collected around an evidence of, almost like from 2008 to 2019. So approximately, if you turn down from minus 15 years to minus 4 years, but then the data point was to ensure that there was at least one visit or more than one visit to the centers, and these data was then collected thereafter to see the progression. This was done across 26 sites in France, Germany, Italy, Spain, and the UK, and it was a retrospective cohort study of longitudinal data from the medical chart reviews. When you look at the methods, the population which was included was above 55 years, and these were newly diagnosed with probable AD with an MMFC scores of between 20 to 28 at diagnosis. The exclusion criteria as mentioned, and the data collections was done for the demographics, the comorbidities, age, sex differences, clinical characteristics, the diagnosis and the treatment, the functional, behavioral, and the cognitive parameters, and then, of course, the caregiver characteristics. Now, when the analysis was done, it was primarily to look at the descriptive statistics, but specifically, there are this LCGM, or what we call as the latent class growth modeling, which looks at, a distinct pattern of change over the time on a variable of interest. And this is usually essential for us researchers in the identification of this homogeneity in a very heterogeneous population, as you have seen across various countries. Then the change point analysis was primarily, to detect any changes in the data, particularly in the time series data. And as I said, this was evaluated between 2008 and 2019. So any point of time and when the events happened, it took place, these all were kind of like recorded as part of the change point analysis. And finally, the analysis through two big analytical tools, which is one, obviously, the SAS, and second, the R. And this was used primarily in the data science to look at in terms of the difference in the cost, differences in the flexibility, and the learning curve between the two or the cohorts. Now, this chart illustrates primarily the cohort as a whole. Now, the MMSE change point analysis was done -5 years prior to diagnosis, -2 years prior to diagnosis, +2 years after diagnosis, +5 years after diagnosis, and +8 years after diagnosis. But of note, there were two changes which was primarily notified. One specifically at approximately between 1 to 2 years. And during this curve, you see that there is a sudden depreciation or kind of like lowering down. And this acceleration in the disease progression is one noted, this is one. And then after 2 years or between 2 to 2.5 years, you see the other curve. Now, of note, the first curve which you see has a more steeper one because this is a period when the diagnosis was done or the clinical evaluation was done, primarily because the disease progression was much faster at this stage. But then the authors say that when you look at the next one, the curve flattens down a little bit at 2.5 years, the reason being that there was some loss to follow-ups, and second, that there were some deaths associated, which means that these are fast progressors, and then there's subsequently a flattening of it. Now, the MMSE trajectories, which was primarily done with the latent class analysis, we observed 3 trajectories. And as you see these 3 trajectories, one was slow, one was moderate, and one was a rapid decline. We looked at in terms of what could be the predictive factors in terms of designing saying that which could be a slow or a fast or a slow, moderate one. We couldn't see any differences between any characteristics except for one, and that too with the slow trajectory, or slow decline, where we thought that, or at least the conclusion was on the amyloid testing. And the amyloid testing primarily could have been the CSF mainly here in this study, but then in one of the slides you would see that how differences this could cause on the amyloid testing also. Now, when we look at the next graph, and this chart, sorry for the very small minute things on, but please note on the amyloid pathology, the last but second row, and you can see that this varies between the countries. Now, we know, ADNET registry publishes its biomarker reports, but when you look at kind of like European nations, no amyloid testing was done in a country like UK. And when you look at in terms of other populations in other countries, it's also bare minimal. On an average, 47% of these population were done amyloid testing through primarily CSF, and this does vary. And who were these patients where this amyloid testing was done? One, obviously, these are younger population, and second, who had comorbidities. Sorry. That's the corporate life you'll see. So regarding the demographics and the baseline clinical characteristics, the median follow-up time was 4.42 years, and the average age at diagnosis was baseline was 75.7, but this varies between countries. Females were predominant, 60%, and the mean MMSEs was a diagnosis was 23.5. And I said the diagnostic practices differed by countries, with amyloid testing quite most frequently done in Germany and absent in UK. Now, healthcare resource is a big component of Alzheimer's disease management, and this comes in terms of the resources. And the caregiver support was one of the key, which was seen in 85% of these cases. And this was done primarily from the spouses or partners and adult children. And these professional caregivers were associated or involved in almost 16% of the case, and the mean number of hospitalizations was 0.9. Now, when you look at in terms of the time to institutionalization and death, It's overall approximately 26% experienced institutionalization or death, and out of that, majority were institutionalized and 7.5% died. But what is important to know is that there is a big assessment or big heterogeneity in these assessment tools, and that's why you need to have a standardized tool for kind of like assessing this. So to conclude, this study primarily identified 3 cognitive trajectories: slow, moderate, and rapid decline. Except for amyloid testing, which was done primarily with the slow, we could not see any predictive factors. The MMSE declined significantly 1 year before diagnosis, as you saw into the graph, and then thereafter, 2.5 years, it flattened out a bit. One objective of the study is also to see any cross-national differences, which was clearly observed. As you see, some had done amyloid testing, some hadn't done amyloid testing. And there is quite a variation in terms of assessment tools. And this finding suggests the importance of personalized care strategies and standardized diagnostic pathways. Thank you so much.
Thanks, Vinay. Any questions? So, Vinay, I suppose it's difficult to ascertain between the different countries that you mentioned there, but is there any area why the different trajectories may be accounting for?
I think Stephanie said about hope something which I remember in the morning session. So there was no treatment options available at that point of time in terms of which could slow the disease progression. That's one thing. Second, probably the awareness.
Sure. Okay, if there's no other questions and we're over time, I might conclude the session. So thanks, Vinay. So finally, I'd just like to thank all our speakers for this symposia. Associate Professor Emma Devenney, Associate Professor Steve Macfarlane, Associate Professor Paul Yates, and Vinay. Today's presentations highlight how rapidly Alzheimer's disease field is advancing, from identifying individuals at risk before symptoms emerge, to improving trial readiness, and now understanding the long-term impact of disease-modifying therapies. These developments are creating new possibilities, and as we mentioned earlier, Steph said, hope for earlier diagnosis, more personalised care, and better outcomes for people living with Alzheimer's disease. So thank everyone for attending today's symposia. There is afternoon tea now, and the next session starts at 4:15. So thank you everyone for your attendance.